All right, well, we'll go from the diarrhea and then a heart attack, and now we're just going to go abuse some children.
Yeah, let's
we're going to talk
keep
about
sliding down that slope.
physical abuse of children. This is actually by Carol Berkowitz, who's a colleague of mine at Harbor, New England Journal of Medicine in April of 2017. This is a New England Journal of Medicine clinical practice article. I like these articles. They're pretty comprehensive. They're usually very practical.
Yes.
I really like these articles. These are pretty good. And the entree to this is child maltreatment includes a lot of different things, from sexual abuse to emotional abuse, neglect, not taking care of your kids, and then physical abuse. And this article is going to focus on the physical abuse only. We're not going to focus on the other things, terrible things that can happen to children.
I don't really want to talk about
No, yeah, exactly. This is bad enough already.
Bad enough already.
So just as a general tenet, and this actually applies to intimate partner violence and elder abuse as well, but the evaluating somebody for possible abuse, and in children in particular, you need to know certain things. So you first of all have to know what is normal development for a child.
Sure.
You know, if they say the child rolled off the changing table at 2 months of age, that just doesn't happen. They don't roll over until they're 6 to 7 months. So you need to know what's appropriate as far as development in a kid. Does this match with the way they developed? And you have to find out the historical events. If a child fell 2 feet off a couch and has a skull fracture, that just doesn't quite jive. Something's not quite right. So you have to know child development, make sure that the history is credible, and then know how to treat what is non-accidental trauma, what is it? So we'll talk about what those injuries and things might be that would sort of make that red flag go off on your head. Know how to treat the injuries themselves, and then know what to do if you really suspect it's abuse. So 5 kind of big components to dealing with the idea of evaluating kids that might be child abuse. And their injuries themselves, when it comes to non-accidental trauma, physical abuse in kids, fall into 4 major categories. One is abusive head trauma, one is abdominal trauma, cutaneous and intraoral findings, and fractures.
Okay.
So we're going to go into each of those in turn. Abusive head trauma itself used to be called shaken baby syndrome, and that's been gone for about 10 years now, mainly because other things probably do it. We're not exactly sure what. Basically, it's just when a child has intracranial injury from some sort of abusive trauma. And those of you who are seeing this on your screens, on your computer, that weird-looking baby on that picture is actually a model with a see-through head. Is actually a mannequin used to show parents what happens inside the child's skull if you shake a baby, so they have some idea of why that could cause some potential harm. And the symptoms when a child has this abusive head injury, abusive head trauma, can range anything from just a little bit of lethargy to being dead. I mean, it's just all across the board. And it makes sense, the group that's at the highest risk here. It's young children and infants. It's not the toddler running around. It tends to be
the ones who cry.
The ones who cry all the time are the ones that are at the highest risk. And when they come in, the symptoms they present with are often nonspecific. And it makes this all fits, right? You know this. They can be altered. They can seize. They may not be eating very well. They might have some scalp swelling, which I think most of us would worry a little bit about. They might be just limp and kind of lethargic. They might be vomiting. They might have had a syncopal episode. They might have apnea. They could have BRU, which is the old ALTI, and now the brief reversible unexplained event. All these kind of non-specific things can be, and think about it, imagine. So I imagine a scenario of a febrile 4-month-old who's crying and crying and crying and crying and crying, gets shaken, has a seizure from the trauma, and then comes in febrile with a seizure. We think that's a febrile seizure, so which is totally fine, just kind of keeping all your spidey sense open for things that might not be quite copacetic. Because if things don't fit in putting the picture together, we need to worry about abusive head trauma. If the kid, it just isn't quite fitting, something's funny here, their behavior's off, they've seized and doesn't make sense. Because about a third of cases are missed. We miss about a third of them, and they come in later with something worse because we've missed it in the beginning. Oops. If you see a baby who might have abusive head trauma, you're going to look everywhere. So you're going to look at their skin and look for signs of trauma. You're going to basically look intraorally for particularly the torn frenulum, where babies have the bottle kind of crammed in their mouths and they can tear the frenulum in their mouth. You're going to do an eye exam, which honestly in an infant is a challenge.
Yes.
This may involve ophthalmology to take a good look, because what you're looking for in the eye is retinal hemorrhages. Now, a couple things about that. I was taught that was diagnostic of abusive head injury. And it turns out it's very common. 85% of abusive head injuries have it. It is not diagnostic, though. Okay. So other things may cause that, but it sure raises the heebie-jeebies that that's what's happening. And if you see a kid with abusive head trauma, you're going to look elsewhere. You're going to order a skeletal survey, and in particular, you're going to pay attention to 2 areas. One is the ribs, and you're going to basically, when they grab a child around the chest and shake, they can break the ribs of the child. So you're going to look for rib fractures, and because their little legs are kind of smacking around, you can look for some of the fractures that are indicative of non-accidental injury, which are metaphyseal fractures. I'll show you some pictures later on this. Of course, you're going to image the brain and skull. If you're worried about it, you're going to go, and if the kid is really sick, if there's something neurologic wrong, you're going to go right to a CT scan. You're going to go where the money is. You're going to go look for the findings on CT scan. If not, though, if the kid is kind of hanging in there, but you're worried about it, MR might be a better study for two reasons. One, they don't have brain irradiation, which is kind of nice to avoid that. And the second is it'll show various aged injuries, so it will show you if this has been going on for more than just today. So it'll show you various age injuries. And you're going to look, of course, for things like anything from diffuse axonal injury to bleeds and everything in between. They basically have pretty much anything in there. One of the things that does it make sense is if a caretaker or a parent comes in and says they just tumbled off their little, the little ottoman in the living room, and now they're vomiting and they have a brain bleed, that's probably not the answer. And that makes you really worried. So, and there are, of course, other factors that are suggestive. A kid that's not breathing, kid who seizes, rib fractures, like I mentioned, these fractures on their bones, or their long bones, or head or neck bruising, which is, all this is making me feel just kind of nauseated, and the retinal hemorrhages. Now, abdominal trauma is much less common than head trauma, but this is the kid that gets punched in the stomach or kicked in the stomach, and this is toddlers more than infants and young. This is the kid that's running around and grabbing at things and pulling things down, and the parent basically just smacks them instead, but hits them in the abdomen. And this we often, because I don't know, I hardly ever think of somebody punching a kid in the stomach, so it's not something that we think of very often as our day-to-day lives. So you have to really put it out there to think about this, because we often misdiagnose this, and if you delay it's an abdominal injury that's going on in there that we're missing. And you would never miss it in a kid who falls off their bike or falls down a flight of stairs. It comes in as a trauma, and it's a similar kind of risk to the kid. Because the injuries are what you'd expect. It's a liver laceration or hematoma. They've ruptured a hollow viscus. It's a duodenal hematoma, which we think of in the handlebar kind of injuries. But of course, if someone punches you in the stomach, you can get it as well. Their spleen, their pancreas, all of those organs, particularly the solid organs, and hollow as well, but mainly the solid organs in there can get damaged. When you suspect abdominal trauma in a kid, and actually any kid you suspect trauma in, just make them naked. And they're cute, adorable anyway. So just take off their clothes and just look at everything.
Check them all out.
You're going to look for bruising of the abdomen, but honestly, you may not see any, even though they may have a ruptured liver, ruptured spleen. So if they're tender on exam and you're concerned, please go ahead and work them up. And then make sure if you see a kid that has abusive head injury, so that kid's seizing or altered, really worry about that abdomen, because they may have had a second injury at the same time. And that's where we're going to do things like order tests, like the lab tests, hepatic labs and pancreatic labs, and maybe even image if you're really concerned. CT with IV contrast is what you're looking for, just like we would do in any other trauma. Ultrasound's not the way to go. Now, we know the third category of physical abuse in kids is cutaneous and intraoral trauma. And the article doesn't go in depth into the intraoral, but I mentioned already the frenulum tears, the thing you mainly worry about in there. We definitely worry about cutaneous injuries, and bruises are what we look for in kids. A couple things. Mobile kids bruise. They fall down all the time. They just fall down all the time. But certain patterns will make you suspicious. Bruises on their butt, like they've been spanked, or their trunk, or on their hands, or bruises in kids that aren't mobile. That doesn't make a lot of sense. Or patterns. It's a handprint, it's a belt, it's a cord, something. So those are the things that really get you worried that this is non-accidental kind of injury. Now, we do know that some kids will bruise more. So kids with hemophilia, kids with coagulopathies, other genetic disorders may bruise more. So having a bruise in and of itself doesn't guarantee that it's non-accidental, but you have to be concerned. And you may go on to work somebody up for coagulopathy if you're really worried about it. Now, the other thing is I was taught that a bruise goes from this rainbow of colors, from this deep kind of purple, and then it gets kind of greenish, and then it gets kind of yellow, brownish, and then yellowish, and then disappears and goes away. Turns out that's a big lie. It's not true. The color of a bruise doesn't determine the age. So even if it's something that looks like it's old, didn't happen today, it may be today. If it's so don't. The burns we know to worry about, and there are certain burns that just, for instance, kids don't burn both of their feet. A kid may step on something hot and burn one foot, but they're going to basically do what you do. You're going to back off. Kids do not burn both of their feet. They don't burn their butt. They certainly don't burn their butt, their legs, and their feet, where they got immersed in the immersion kind of things worry you, and patterns. Cigarettes, crack pipes are used to burn kids. Irons, curling irons are used to burn kids, other heated objects. So those are all very indicative of non-accidental trauma. And then the last group of injuries is fractures. If you're worried about a fracture in a kid that you think is non-accidental, you really are obligated to do a skeletal survey, because if you think it's on one extremity, it might be elsewhere of varying ages. So All kids under the age of 2, when abuse is suspected any kind, the burn kid, the kid who's a little lethargic and you think it's an abusive head injury, any abuse of a kid, you're going to want to get a skeletal survey. And all kids under 2, even if there's no evidence of a fracture, and then all kids over 2, where the fracture, it looks like it's an inflicted kind of fracture. And what you're going to get is basically everything head to toe. The skull, the CTL spine, ribs, humeri, femurs, pelvis, hands, and feet. And honestly, the kids are usually little enough that they just kind of stick them on one of those things, take a couple pictures, and they get all of it at once. So it's pretty easy to get these skeletal surveys. And when you get them, you're going to look for certain things. So any non-ambulatory kid with a fracture, you have to worry that that might have been inflicted. We'll get into the group where it might be actually medical, but you have to worry. Metaphyseal lesions, and this picture shows these bucket handle or chip fractures where, again, this is either the shaken child, the legs are moving around, or the child is jerked around, and it cracks the edges of the metaphyses. That is highly suggestive of an inflicted injury, as are the rib fractures I mentioned. So lateral and posterior rib fractures are squeezing. Stop crying, and they squeeze the child, and they can break their ribs with that way. Sometimes you can see them acutely. Sometimes you'll need to either repeat the films in 2 weeks or even get a bone scan to see, because the kids are a lot of cartilage and not a lot of bone sometimes, so you may need to actually get a bone scan. And any sternum, scapular, or acromion fracture should make you worry. We worry in adults because it takes a lot of trauma to do that in an adult, and it's really hard to break those in kids. Now, the fracture thing is not all easy, though, because there are diseases like rickets, which actually some kids get because they're vitamin deficient, or osteogenesis imperfecta. We tend to think of osteogenesis imperfecta as that horrible, the adult in the wheelchair who's had 5 million little fractures but it ranges from in utero breaking your bones, where it's just really terrible osteogenesis, to actually a milder form where it does take a little bit, not a lot of trauma, but a little bit of trauma to actually break it. So osteogenesis imperfecta, that's probably the area where we could erroneously accuse someone when they have a child with undiagnosed osteogenesis of one of those sort of less severe types. The other thing to know is there are certain kinds of fractures in the right setting that are just what happened in some kids. So one of them is called a toddler's fracture. So you got this cute little fat-legged kid toddling around, running around, and they plant a foot, and they twist before that foot comes up, and they can get a spiral fracture of the tibia. That is actually can be a completely normal mechanism in a kid. But if it's a non-ambulatory kid, that shouldn't happen. So that doesn't make sense. So if you want to assess a child that might be child abuse, there are kind of 8 steps that Carol goes through in this paper to go through. The first is obtain a history. So what happened? Who was there? What did you do after it happened? Were there witnesses there? Did you come in right away? All the things that we know to ask, because if they delayed or they just let the kid sit there and scream with that broken leg, it's like something's wrong. And does the developmental history match what supposedly happened? If they couldn't walk and now they have that fracture, something's funny. Did it all make sense? Basically, does the history make sense? And then you're going to do an exam again. You're going to make them naked, and you're going to look everywhere. And one of the things in kids that might be abused is to look at their overall. Are they clean? Are they fed? Are they dehydrated? Those are signs of neglect, which is a whole other thing, but that's also the kid that's at higher risk. You're going to look on the skin, you're going to look in the mouth, look for subconch hemorrhages, which again you can see with shaken baby, where whatever, the abusive head injury. And if you see something, you probably should take a picture. And if you get law enforcement involved, which can happen depending on your state, maybe mandatory, they may want to take some pictures on this if it ends up being something that might go to court. Now, once you've done the history and physical, you're of course going to order the appropriate stuff. The sicker the kid, the more urgent you're going to do things. You might need the head CT scan right away. You might need the belly CT scan right away. You might need to give blood, whatever. You need to resuscitate. You're going to do what you think is clinically appropriate. But you also are going to image appropriately, so skeletal survey may be indicated, and you're going to order labs, including things we don't normally think about in kids, like LFTs, amylase, and lipase. So order those, particularly for the liver and the pancreatic injuries. And this may be a time to call in ophthalmology and say, you make the big bucks. You come in and please take pictures of the fundoscopic exam of these kids. You're going to manage these medical problems once you diagnose them, figure out what's what, and then you've got to notify Child Protective Services. Now, this is a state-by-state thing. So if you work in healthcare, you need to sort of know what your state requires. Sometimes they require you to call law enforcement. Sometimes they don't. So you're going to have to know in your state what you need to do. And then your job is to protect that child. So you will hospitalize if needed medically, of course, but sometimes you'll hospitalize because it's safer for the kid to keep the child out of the home, to hospitalize for the kid. The other thing, because this came up relatively recently at our place, is if there are other children in home, make sure Child Protective Services is aware of that so they can go see if the other kids are safe. And then these agencies that get involved do kind of cool stuff. They come in and talk to the family, and they look at the home situation, and they sort of do a very detailed social evaluation, because it isn't always evil people. It's sometimes just really, really tired parents who don't really know what they're doing can harm their kid.
And there could be other caretakers involved.
Right,
and
yeah.
collateral people.
Right,
We gotta
and the
figure
most,
all that out.
yeah, and it's not in this paper, but the most common abuser is the boyfriend.
Right.
Tends to be the most common abuser. If you look at statistically, that's the most common. Then the last part of this is, remember, not all of these things that look like they're abusive injuries or inflicted injuries are. So sometimes you're going to need to do things like a workup for osteogenesis, a workup for blood dyscrasias. Maybe this child is a bleeder of some sort. They have a coagulopathy of some sort. Other medical problems like, do they have rickets, and which is not that common, but definitely can still occur. Skeletal survey you're going to repeat, maybe a radionuclide. There are other things that may be indicated. So that's the 8th step of this, kind of putting the package together on a kid that might have been abused. The best thing is to prevent it. So one of the things these just angels on earth, these trained personnel that go to homes and talk to parents and educate parents about certain things, and the 2 major areas to educate parents about, all we just talked about might be a third, is infant crying. So when the baby cries, there is a mantra, which is carry them around, comfort them, walk and talk, coo to your baby, and then if you think you're going to explode, put the baby down and walk away. So the walk
Crying
away
won't kill them.
Crying won't kill them,
Yes.
and walking away
Better
doesn't mean
than
you're a
getting
bad parent.
frustrated,
It just walk away. So that's one of the infant crying is one major area. The other is toilet training. So the other kind of peak of child abuse happens around the time of toilet training, and trying to just explain to parents what's appropriate. Kids will have accidents. And they can have accidents for years. So that just is a normal part of toilet training, and parents need the education on that. We were just talking about a paper that just came out that looked at child abuse around the time of report cards that peaked it if they were given on Fridays. Kind of interesting. So certain precipitating events. So don't beat your child for the report card. So to summarize this article, which is actually quite well done and relatively detailed, just to summarize, there are 4 major areas of physical child abuse. One is the abusive head trauma, abdominal trauma, cutaneous and intraoral findings and fractures, and there are 8 steps to go through in the evaluating child abuse: getting your history, doing your exam, getting the appropriate workup, managing those medical problems, letting Child Protective Services know, hospitalizing the child if needed for medically or for their safety, having all the appropriate agencies do what they do, which is that social evaluation, and then considering a forensic workup if it's indicated. So now you know everything about child physical abuse.
Really good reminders.
Yep.